Thank you. So hi everyone. So my name is Nhung Tring, and I'm a postdoc at Department of Pharmacy, University of Oslo. And actually, I have been following the growth of the EDENs and also the development of OMOP Common Data Model since I was still a PhD student. And I was so glad to be involved in the mapping work where we map Norwegian data onto OMOP Common Data Model. And I have attended quite a number of presentation by data partners and also SME where they share about the experience. And so we are in the state that we can share our mapping challenges and experience in the project that we have been since October 2021. And I'm presenting today on behalf of a team at UIO and EdenceHealth with different expertise, and they have been working hard to make it possible for University of Oslo to participate in the project use OMOP Common Data Model. So this is where we are in the Eden maps. We are one of the two data partners from Norway, together with the Norwegian Cancer Registry, and our journey started in October 2021 with the grant for the mapping work from Edens. So a little bit about Norway. So in Norway, we have a universal healthcare system, and everyone with so legally a resident in Norway has access to the healthcare system. And between 2018 and 20, we have roughly about 5.5 million inhabitants. And each of us has a personal ID, which allow us to link the data from different national registry. And for this project, at the beginning, we decided to map 5 different registry, which is really relevant for the study, for the research interest of our research group, which is the MBRN, Medical Birth Registry of Norway, NorPD, Norwegian Prescription Database, NPR, Norwegian Patient Registry, CISVAC, is Norwegian Immunization Registry, MSIS, which is Norwegian Surveillance System for Communicable Disease, and in an updated mapping, we are going to map also the Norwegian Control and Payment Health Reimbursement Database that we call KU, and the detailed information about these databases that we put into the Eden portal that you can find. But I can introduce to you briefly today about the information that we store in each of the database. For example, MBRN, Medical Birth Registry of Norway, is coordinated by the Norwegian Institute of Public Health, where we have information on all the pregnancies that lasting longer than 12 weeks in Norway. So we have very detailed information, pregnancy-related information from this registry. And in MSIS, we have information, all the positive tests for certain conditions, including COVID-19. The Norwegian Prescription Database, NorPD, where we store all the information regarding the dispensation of all prescription fill in retail pharmacy in Norway. And in NPR, we have information regarding the specialist care utilization, hospital contact, and also the hospitalization in all over Norway. And in CISVAC, we have information on the vaccination status of all residents in Norway. And also for the KU database, we have consultation with general practitioners and specialists in Norway. So this is the figures in overview of our mapping process. So I think it's a bit different compared to some of the data partners that our source data need to be stored inside a secure platform called TSD that coordinated by the Center for Informatic Technology at University of Oslo, where we don't have the internet access, and all the exportation and also the importation of data in and out of the TSD need to follow a very strict regulation to protect the personal information. So because this is the collaborative work between UIO and EdenceHealth, so we use the White Rabbit tool in order to profile our data, and we send the scan report from our source data to EdenceHealth, where they later on created a list of mapping code and sent back to us. And we use Athena in order to transfer all the non-standard code into a standard one. And also the data profile that we sent to EdenceHealth were used to simulate the data. And then the SQL, the ETL were built on this simulated data at EdenceHealth, and then all the SQL related to this ETL would transfer back to DSD people, to USIT people, in order to transform our source data into data in OMOP format, and all the ETL execution and also the data quality check was everything were done in a Portman container inside TSD. So basically, EdenceHealth doesn't have any direct access to our data, and everything was done by our personnel. So I think this information is quite important for some of the data partner has a similar data regulation as us, as I discussed with some data partner from Danish that also interested in mapping OMOP common mapping the data into the OMOP common data model. So here I will talk about the coding system in the source data and how our vocabulary mapping was done. So as I said before, we send the data profile using YRabbit to Eden, and they created a list of 218 non-standard map, non-standard code for us to transform into standard one. So in MBRN, actually MBRN, the information were collected using a questionnaire for the mother and the healthcare physician. So we use a custom classification where information was were at a very high level of detail. For example, this I put an example in here as a server equal to 12 is mean the number of previous miscarriage before 12 weeks of gestation, and normally we don't find this information in the standard code within Athena. So all the custom classification were done using the hand mapping by UIO team and validated by EdenceHealth. And in NoPD, we don't use a custom classification, but ATC, so it was automatically mapped by Edens. In APR, we have two different type of classification, ICD-10 for diagnosis, so it's very straightforward, and it was mapped automatic by EdenceHealth using the community mapping. And in addition to that, we use some of the code classification for procedures, for example, the NCMP that I also see in the FinOMOP, where we have a code related to a certain condition. For example, this one related to respiratory treatment, invasive ventilation, and these it's not the international, the national classification will also map using the hand mapping by UIO team and validated by EdenceHealth. And in MSIS, we also use the national classification. For example, the diagnosis number equal to 713 as main coronavirus, and this was also done by hand mapping. And in CISVAC also, we don't use the ATC for vaccine, but a national classification. So this was done also using the hand mapping. And in total, we have 217 code that we did by hand mapping, and some of them we could not find a standard vocabulary, so we created 38 custom concept. So the definition of the custom concept is the terminologies in our data that is not supported by the standard vocabularies. For example, the one that I put before in the slides that you see, whether the women has the number of previous miscarriage before week 12 of gestation, and also the one between week 12 and week 23. And also we have some of the information also very specific in terms of timing related to pregnancy. For example, smoking before pregnancy, smoking during pregnancy, smoking at the start of pregnancy, etc. So we try to capture all the information as many information as possible in our mapping. So that is the idea where we need to create the custom concept, and this one will be shared with the community in order for the pregnancy study, in case you also have the same similar information that you also need to map using your custom concept. Because of this, so I also mentioned that the drug and also the diagnosis were mapped automatically by EdenceHealth using the community mapping. So the number code map using our process 100%. So we don't lose any information in our source data compared to what we have in the OMOP data. So the number of drug and also visit occurrence and measurement, very high number, but we don't miss any information. So I will talk a little bit more about the ETL design and the implementation.
You've muted yourself, Nhung. Nhung, you've muted yourself.
So the ETL was designed by EdenceHealth based on the mapping logic that defined by with University of Oslo. So at the beginning, we have the mapping workshop where we go through the all the structure of the data and discuss with EdenceHealth on what information we map into which data. And these were tested using the simulated data before transferring to UIO. And the ETL were executed by a Python script which orchestrate a different transformation by calling as SQL script. I used it, and we had a very nice back and forth feedback between EdenceHealth and Lucid in order to improve the ETL during the implementation. Um, why back and forth feedback is because I mentioned also in the overview of the mapping process that EdenceHealth do not have direct access to our data. So all the error that appear during the implementation on the source data, we need to send those information to EdenceHealth, and they try to improve the ETL that they created on the simulated data. And this one is also some of the thing important. I believe important, but I don't know whether they were partner also follow the same pathway, that all the results from each of the transformation are stored in the temporary table before transferring into permanent one. So this is quite important because some of the time your ETL or SQL script will not run with some error, and this is allow you to like store the temporary information in that, so you don't need to rerun that again, because each of the time when you run the SQL in order to transform the data from the source data into the OMOP Common Data Model, it takes really long time. So the script written by Edens also have a lot of comment throughout that allow for an easy code handover after the project finished. So this is relevant for the data partners that need the support from SME. So we map our data into the OMOP Common Data Model version 5.3.1. So these are the table that we map data into. So you can also see in here that the condition occurrence and condition error, and also drug exposure and drug error. So those table has this very similar information that feed into this table from the source data, but the level of detail is different. So I believe that this is one of the things that we learned from the study-a-thon that we had earlier this month in Uppsala, that if you work with network people, that they created the study package, they always assume that you have a full mapping. So some of the data partners only map their data into condition occurrence table, but not the condition error. Basically, the information is the same, but they would prefer to have two tables. So they assume that you have these table, and I think it's really important for all the data partners to have these two table map before you participate in any study-a-thon and network studies. Using the current data in our current mapping, our OMOP Common Data Model cover about 5.5 million individuals. Among those, we are able to identify about 700,000 pregnancy, and also we are able to identify mothers, father, and children belong to this pregnancy using a fact relationship table that we created in addition. So this is very strong, a strength of our data where we have the mother, father, and child linkage within MBRN. And these numbers is only for 3 years between 2018 and 2020. And we expected much more when we have updated data, for example, the one until the end of 2021. So this is the count in each of the table that I mentioned in the last slide. So we have about 200 million count in the drug exposure table, and which is further reduced to about 74,000 in the 6.5. I'm sorry. So this is 74 million count in the drug area table, which is very substantially reduced from the number in the drug exposure table, because the level of detailed information that you have in two different databases is different. So about the technical infrastructure that you need to install everything and make everything ready before you participate in any network studies, the ETL, and also where we have information on inspection report, cutoff entry that allow people to have information regarding your database within Eden portal. Atlas is also important when you run a network study, and especially RStudio and also HEDES or package is really important. So I particularly mentioned HEDES or package in here need to be installed because our data we don't have in our platform. We don't have the internet within TSD, so everything needs to be installed in advance. Otherwise, we cannot call for these the install the package. Because normally they assume that you have the internet, and which is not the case in our platform. And some of the lessons learned from our mapping process, we were able to successfully map Norwegian registry data onto OMOP Common Data Model using Odyssey tool with a very high level of concordance. And we are one of the very few data partner with pregnancy data. And several important pregnancy-related variables could not be mapped using standard concept where we need to create some custom concept. And also a pregnancy extension table might be needed for future version of the OMOP Common Data Model to support pregnancy studies. So this is the ongoing work that we have been doing with CDM and Health Information Center at University of Dundee. And I also take an opportunity of the presentation today to introduce you to our study request, a pregnancy study within EHDEN network. So our first study will provide a full overview and characterization of medication used in pregnant women with and without COVID-19 using the most extended data from different data partners. And so far we have about 10 different data partners that show interest. And for the data partner participated in study, we have some criteria that it should be possible to identify the start and the end of each of the pregnancy in your data, and it should be possible to link pregnancy data with COVID-19 diagnosis test or with recorded date, and it should be linked also with drug dispensation in outpatient setting, and we will send out a form to the interested partner where we request some of the count regarding the number of pregnancy in your whole database, number of pregnancy with and without COVID-19. And if you are interested, and please send me an email to my email address here to if you're interested. And yeah, and later today I will send you the form. And yeah, I would like to thank all the people listed in here that has been supported during our mapping work. And yeah, this is the end of my presentation, and I'm at your disposal for any question.